Vamos a esperar a terminar las dos sesiones para las preguntas. Tenemos la inmensa suerte de tener a Katherine, la doctora Katherine Darling, de la Universidad de Lausana para la siguiente presentación. Ella es médico, es investigadora, ha trabajado muy ampliamente en estudios impulsados desde la Corte Suiza y otros estudios. Trabajó previamente también en el Imperial College en Londres. Entiende español, habla español, pero nos va a hacer la presentación en inglés y luego en la ronda de preguntas, como queráis, podéis hacerlas en español o en inglés. Si hay algún problema, las traducimos. Muchas gracias. Gracias, Katherine. Por favor.
Muchas gracias. Hola. Gracias. Thank you so much for the organising committee for asking Timur to come and present the data, and particularly for your welcome this morning. Timur Nora isn't able to present it, so I'll be doing this on his behalf. These are my conflicts of interest. So what we'll cover now that you've seen the Spanish data is the distribution of HIV in the WHO European region, the targets we're missing and why it matters, the context for the current study, and then I'm going to show the data for the Europe-wide study performed by the ECDC and EACS. I'll just quickly give a stigma definition to anyone who doesn't speak Spanish in the room. So stigma is a series of negative beliefs, feelings, or attitudes towards people living with HIV. It's been really helpful to see Jose present the data about Spain. What I'm going to show is a bigger overview of the rest of Europe. So of the 2.3 million people who were living with HIV in the WHO European region in 2022, you can see that the majority were in the eastern part of the region, 1.4 million, almost two-thirds. In the centre, 56,000 cases, and in the west, 828,000. And just to put this into context, you can see that in 2022, there were 766,000 people with HIV in the European Union and the European Economic Area. The reason I'm showing this map is just that you can see that the WHO European region actually includes part of Central Asia, so it's a much bigger area than the EU. And the other reason I'm showing that is to make sense of this graph. So these are estimated new HIV infections in Europe since 2010. In the lower line in blue, that's in the EU, EEA, and in the upper line in red, that's the WHO European region. So this shows the incident infections since 2010. And I'm showing this because Jose mentioned the 75 reduction target by 2025. So these are data up until 2023, and you can see that in the EU, the number of incident infections has dropped by 35%, but it's not the 75% reduction target. In the Union, the WHO European region as a whole, the incidence is actually increasing. And if I remind you that 2025 starts in 5 weeks from today, you can see that there's no way that we're going to achieve the 2025 targets. The other target that we're going to miss is that the proportion of people living with HIV experiencing stigma and discrimination should be under 10%. And this is a big problem because if you don't address stigma, then it affects our ability to achieve the other goals. And I'm talking about access to healthcare, treatment adherence, and general well-being. One of the reasons that we're a little bit behind with stigma is simply because we lack data. And the ECDC has been committed to addressing this by performing large-scale collaborations. I'm just going to very briefly talk about stigma in the community before I present the healthcare setting data. So the community data, this was among people with HIV, and what they found in this sample of over 2,000 people was that 59% found it difficult to tell people about their HIV. So nobody had told, for example, family members, friends, and current sexual partners. And what these figures tell us is that of people living with HIV, there is a significant proportion for whom the only people with whom they can talk about their HIV are healthcare professionals. And yet, we see that half people living with HIV are worried about being treated differently in healthcare settings, and a third avoid healthcare settings altogether. These data were shown before, but this time they're in circles. So what we wanted to do was to see what exactly is going on in healthcare settings. And I'll just mention that with any infection pandemic, stigma is often related to poor knowledge and fear. And so these were the two axes that we want to address. So the steering committee was invited by EACS and ECDC to take part. And I've put this in green because I just want to highlight that as well as healthcare professionals, there were people living with HIV and also representatives of communities of people living with HIV across Europe. And I commend the leaders of this study for making sure that everyone on the steering committee had a voice. The survey was a modified version of an existing questionnaire. It was translated into 38 languages and administered last year across the 54 countries of the WHO European region. Clinical and non-clinical professionals were included, and I've put non-clinical in green because every big study up until now includes doctors and nurses, but no administrative staff, and yet any person presenting for clinical care will see a receptionist as their first point of contact. So it's vital to include non-clinical staff. The professionals were recruited through a non-probability sampling frame, and so the results should be interpreted with caution, but by this method, the study was able to recruit 18,430 healthcare professionals. This is a brief breakdown of the respondents, so 74% were female. Most were doctors and nurses, but there was 7% in management or administration, 2% were dentists. The majority worked in hospitals, and as you can see, there was a good breakdown of the different services included. I'm now going to talk about HIV knowledge, and I just want to stress that the point of this study is not to shame healthcare professionals, it's simply to gather data. I'm just going to spend a bit of time on this slide because it's quite key in then presenting subsequent slides. So this was a question on key principles of HIV transmission and prevention. So U=U, PrEP and PrEP as described by Jose. So for each question, it was a statement about each of these messages. If the person agreed with the statement, which was true, that meant that they had HIV knowledge. If they disagreed or didn't know, then that was counted as not having HIV knowledge. And so in this way, we're able to say whether people had low or high knowledge, depending on the number of statements they answered correctly. So as you can see here, people with no correct answers had no HIV knowledge. 1 out of 3 correct answers were considered having low HIV knowledge, medium HIV knowledge in blue with 2 out of 3 correct answers, and high HIV knowledge in green with all 3 correct answers. So roughly half the population had no or low HIV knowledge, and the other half had medium or high HIV knowledge. With respect to the 3 specific questions, so 61% had correct knowledge on U=U, 56% on PEP, and slightly lower at 41% on PrEP. And when we break this down by healthcare professional, you can see that, that the data are here, but even doctors had U=U knowledge lack of 31%, and half didn't know about PrEP. When we break it down by healthcare facility, I just want to bring your attention to the columns on the right-hand side, so primary healthcare centres, where you can see that around half of the professionals didn't know about U=U, and only a third knew about PrEP. By geographical area, there's a slight dip in the areas of Eastern and Central Europe compared to the other areas. And as you would expect, people who had no contact at all with people with HIV had lower knowledge than people who frequently were in contact with people with HIV. This is as you would expect, but the graph is still quite striking. Then going on to attitudes and behaviours. So people were asked about their level of worry about HIV acquisition when performing certain clinical tasks. And we found that 53% of respondents were worried when dressing wounds, and 57% were worried about HIV acquisition when drawing blood. A breakdown by professional role shows that students had the highest degree of worry, but even 43 to 49% of nurses and doctors were worried about HIV acquisition when performing these tasks. When looking at excessive measures, we found that 8% avoided physical contact altogether with patients, and a quarter wore double gloves. Again, and as you would expect, we saw that the higher the level of HIV knowledge, the lower the level of worry, and the lower the proportion of people undertaking excessive measures of precaution. Then we talked about preference and reasons not to provide care to key populations. And what we found was that 6% of respondents preferred not to provide care or services to transgender men and women, sex workers, and men who have sex with men. This increased to double to 12% for people who preferred not to provide care for people who inject drugs. Breaking this down by region, you can see that across Europe, people most often preferred not to care for people who injected drugs. And again, in Centre and Eastern regions, the preference was greater to not care for key populations. The reasons for not wanting to care for people was not receiving sufficient training, believing that these groups engage in immoral behaviour, and believing that these groups put them at a higher risk of disease. And finally, I'm going to show you the observed stigma and discrimination in healthcare facilities. So this was observed stigma and discrimination as presented by Jose during the past 12 months, where 18% described observing a poorer quality of care towards people with HIV, 19% observed disclosure of HIV status without consent, 22% an unwillingness to care, and 30% discriminatory remarks or talking badly. So these figures are way off the 10% goal of reducing stigma to less than 10%. So in conclusion, we've seen with a previous study that there's evidence that people with HIV are worried about being treated differently in healthcare settings, sometimes avoiding healthcare settings altogether. There are gaps in HIV knowledge in key concepts on HIV transmission and prevention. We also observed lower HIV knowledge associated with higher levels of worry when providing care to HIV and higher use of excessive precautionary measures. And a number of healthcare workers stated that they preferred not to care for key populations, especially people who inject drugs. A significant proportion had observed forms of stigma and discrimination towards people with HIV in the workplace during the preceding 12 months. And what this study has provided is a baseline with which to combat stigma. This is the first time that many of these questions have been asked, and it's useful to see the entire panel across different European regions. Obviously, what I provided here is a summary of all regions, and ultimately for a paper there'll be a more detailed breakdown. I just want to add some messages of hope, because I said that at the beginning of this talk that a lot of stigma is related to lack of knowledge and to fear, but it doesn't usually last for 40 years. And I think we can all agree that milestones in HIV stigma have lagged behind the medical advances for HIV prevention and treatment. But I would say that had this study been done 10 years ago, we would have examined stigma in a very different landscape. So being optimistic, now is absolutely the time to look at this sort of data in order to improve healthcare setting for people with HIV. This study provides a baseline, and we can't combat stigma without knowing where it is. And I would say that the scale and the range of this study makes it in itself a first stigma milestone. With the study data, healthcare professionals can acknowledge there are gaps, and they need to acknowledge this before they're willing to embrace change. Interventions, I believe, can be targeted and swift, and I look forward to seeing this being put in place. It's entirely feasible. I'd like to finish by acknowledging Ana Mendez-Lopez, who was the lead consultant for this study, Taimur Nouri at the ECDC, and Esteban Martinez at EACS. And I'd like to thank you very much for your attention.